Dr. Ram Chadda has also joined. Welcome, sir.
Good evening. Good evening.
Good evening, sir. Pleasure connecting with you, sir.
Good evening,
I
Dr. Ram.
apologize. My laptop was in a slight issue, so I apologize. I'm now joining from my phone. I apologize.
Yeah, good evening, Dr. Ram. Hi,
Good
Mangesh
evening.
here.
Can you hear me? Can you hear me?
Yes, but you are not able to see you, sir.
I'm trying to now make myself visible. I don't know how it's going to be possible, but I'm trying.
Good evening, Dr. Ram. From
Good evening, Ji. Good evening. Good evening.
It's from Calcutta, Dr. Paul.
Hi. Good evening, Dr. Pal. Good evening. Just give me a moment. Trying to sort out this thing on my
See you,
phone.
sir.
You can't see me, right?
Yeah, still not now, not till now.
Let's see. Let's see if I can do something. Phone is become a challenge. Anyway, let me see. Let's start with the meeting.
Right. Hi, Dr. Ram.
Good evening.
Hi,
How are you
good evening,
doing?
Dr. Diwan here.
Good evening, sir. Good evening.
Right. So Alad, I think you can ask the Integra guys to do the countdown and they can start it.
Yeah. Science Integra tech support.
Yes, sir.
Yeah. So it's about 8:29. Are we good to go?
Tech support, please give the countdown. Then start.
Sorry.
Aditi, your voice is not clear.
No, tech
Hello,
support will give the
am I
countdown now.
audible?
Okay, sir.
Yeah.
So about
Now 5, 4, 3, 2, 1, live.
wish you a very, very warm welcome and a very good evening. On behalf of Juventus Odinia, it gives me immense pleasure. I'm Allad Mahajani, Vice President Marketing. And with me is Mr. Jatinder Jindal, the Brand Manager for Pole Vault, Colmocoxet. It gives us immense pleasure to welcome each one of you, for a roundtable meet, or we can say webinar on discussion of emerging options in management of chronic pain. Juventus Odinia happens to be a pain management division of Juventus Healthcare, and we feel very happy and proud to share with you that there have been multiple concepts in pain management which we have been bringing to the market for the first time, right from tolperazone, which was for the first time in the country, followed by patches, followed by S-Itodolac, which was the second brand in the market, followed by the management of chronic osteoarthritis and pain, which was Tendoform, right? So we as a company believe that for providing relief to the patients, newer pain option management should be brought to the marketplace. And one such introduction, which we have done very recently or on the verge of being launched, is Polmacoxib. Today, we have immense pleasure to have our Medical Director, Dr. Bhupesh Diwan from Juventus, who has 28 years of experience with top pharmaceutical companies and who has conducted more than 100 clinical trials and published multiple research papers and in national peer-reviewed journals, who is with us, who is going to moderate this discussion. And we have esteemed faculty members, Dr. Ram Chadha, Dr. Anand Kishore Pal, and Dr. Mangesh Tivaskar with us. Right. I would hand over this session to Dr. Bhupesh Diwan so that he can introduce the panel and take the discussion ahead. Thank you, Dr. Diwan.
Thank you, Alad. Thank you very much. And a very good evening to all the participants in this webinar. So I would like to introduce our esteemed panel over here. First of all, I'll start with Dr. Ram Chadha. Dr. Ram Chadha is a consultant orthopedician and spine surgeon at Leelavati, Bandra, Jaslok Hospital, Pedder Road, and Global Hospital, Parel. He's having 34 years of rich experience in field of spine surgery, presently DNB orthopedics guide and teacher at the Leelavati Hospital and research center at Bandra. He is president-elect for the Indian Orthopedic Association, and he's got pioneer of MICOS, minimally invasive cosmetic spine surgery in India, Dr. Chadda is a regular keynote speaker and a guest orator at scientific conventions. He's a part of Federation of Delegates for India at the Asia Pacific Orthopedician Association, on editorial board of Asian Spine Journal, the Indian Spine Journal, and Malaysian Orthopedic Journal. And recently, he's pioneered robotic spine surgery, which is a innovation at Navi Mumbai. So we welcome Dr. Ramchadda. Next panelist is Professor Ananda Kishore Pal. He's a consultant orthopedician surgeon from Jalpaiguri Medical College. He's professor and head there. He's been the vice president of West Bengal Orthopedic Association, former head Department of Orthopedics and Traumatology at IPGMER SSKM Medical College, the Center of Excellence in Kolkata. National CME lecturer for AO Basic, Advanced and Master's course, examiner of Diplomat and National Board of Orthopedics MS, immediate past editor of Journal of West Bengal Orthopedic Association, reviewers of Indian Journal of Orthopedics, 43 international and national publications in Index Journal. Dr. Paul is well accomplished. So he's got gold medal for the best presentation in pediatric session. Is award for Indian Journal of Orthopedic, and AA Mehta gold medal in National Conference of IOA. Welcome, Dr. Professor Ananda Kishore Pal. And now our another gold medalist, Dr. Mangesh Tivaskar, very well learned doctor. He's MD, FRCP, FACP, FICP, FGSI, Diploma in Advanced Diabetology from Denmark. He's consultant physician and diabetologist at Shilpa Medical Center, Mumbai.
भूपेश यार छोड़ देना, डॉक्टर रामचड्डा का फ्रेंड है बोल के बोलता है. That is adequate introduction for me.
Yeah, but Dr. Saab, people should know who Dr.
That's
Mangesh
okay. That's all right. Doesn't matter.
Great. So, so with this, he's, by the way, editor-in-chief of JAPI. So with this, I welcome Dr. Mangesh Tivaskar to this panel. And with this, we start the show. And to begin with your permission, Dr. Mangeshkar, Dr. Tivaskar, should we start the small presentation?
Yeah, that is good enough. So let us set the ball rolling.
Okay, sure. Jatinder, can you just share the video?
वीडियो सर अभी आपने स्टार्ट किया था.
Okay, all right. I'll try to share it. Yeah. Just hold on. Just a moment. I think there is something. Please let me know if the sound is there.
Pulmocoxib is an emerging solution for the management of inflammation and pain. A unique non-steroidal anti-inflammatory drug with a better safety profile and dual mode of action, Polvolt 2 mg blocks both carbonic anhydrase and cyclooxygenase 2 enzymes. Currently available, first-generation NSAIDs like naproxen, diclofenac, ibuprofen etc. are non-selective and inhibit both cyclooxygenase 1 and cyclooxygenase 2 enzymes, leading to gastrointestinal and cardiovascular side effects. Therefore, to overcome these adverse effects due to cyclooxygenase 1 dependent mechanisms, several new selective cyclooxygenase 2 inhibitors have been developed. Introducing Polvolt Pulmocoxib, a next-generation NSAID with tissue-selective cyclooxygenase 2 inhibitor. A first-in-class NSAID, which is a dual inhibitor of cyclooxygenase 2 and carbonic anhydrase enzymes. Tissue-specific, once-a-day orally active drug with half-life of 5 days. Carbonic anhydrase concentration is very low in the inflamed joints and tissues, whereas cyclooxygenase 2 concentration rises in the inflamed tissues. The greater the distribution of carbonic anhydrase in the tissue, the lesser the inhibitory action of cyclooxygenase 2. Wherever cyclooxygenase 2 and carbonic anhydrase coexist, high affinity and preferential binding of pulmocoxib to carbonic anhydrase takes place, thus reducing the cyclooxygenase 2 inhibitory activity of pulmocoxib. Cardiovascular side effects are reduced since cyclooxygenase 2 enzyme is spared in cardiac tissue. Importantly, low-dose administration of pulmocoxib, only 2 mg, has shown to have a negligible inhibitory effect on the required carbonic anhydrase enzyme function in the circulatory, gastrointestinal and renal system. There are many advantages of pulmocoxib over other cyclooxygenase 2 inhibitors like celecoxib. Pulmocoxib is a first, tissue-specific and selective, once-a-day osteoarthritis drug with half-life of 5 days. It has unique mode of action. It is a dual inhibitor of cyclooxygenase 2 and carbonic anhydrase 1 and 2 enzymes. Due to this unique mechanism, pulmocoxib specifically targets affected or inflamed joints only, and healthy tissue is spared of the side effects. Quick onset of relief from the signs and symptoms of osteoarthritis in comparison to celecoxib. It has highest potency among the available NSAIDs. Only at a 2 mg per day dose, the lowest dose amongst all known NSAIDs. Convenient once-a-day regimen provides better compliance in patients, unlike most other NSAIDs, due to long half-life of pulmocoxib, which is approximately 5 days. Long-term safety established in long-duration studies extending up to 6 months of continuous usage. Pulmocoxib with once-a-day administration shows enhanced gastrointestinal and cardiovascular safety. The half-life of a single dose of pulmocoxib is approximately 5 days. Pulmocoxib is excreted both via feces and urine. Indications and dosage administration. It is approved for the treatment of osteoarthritis of hip and knee joints. Recommended adults dose is 2 mg once daily. Maximum dose should not exceed 2 mg per day, since the drug is slowly accumulated in plasma and reaches steady-state concentration in a few days. Clinical evidence of pulmocoxib in human clinical studies. In this phase 1 clinical trial, pulmocoxib was well tolerated. There were no clinically significant changes in blood pressure between the treatment groups. Pulmocoxib suppressed serum thromboxane B2 and prostaglandin E2 at all 3 doses. A clinical study evaluated the influence of ketoconazole, a known strong inhibitor of CYP3A. The area under the curve increases for pulmocoxib, but doesn't change the safety profile of pulmocoxib. Pulmocoxib showed quicker onset of relief from osteoarthritis as compared to celecoxib. Pulmocoxib showed statistically significant superiority over placebo at week 3, but celecoxib did not show statistically significant difference from placebo at week 3. WOMAC physical function scores at week 3. Pulmocoxib demonstrated better efficacy against celecoxib in all other efficacy endpoints, including WOMAC pain and stiffness subscales at week 3 and week 6. Pulmocoxib showed superior efficacy over celecoxib with statistical significance in physicians' global assessment score. 77.7% of patients taking pulmocoxib experienced improvement in signs and symptoms of osteoarthritis as compared to 58.9% in celecoxib group. Safety conclusions from 24 weeks pulmocoxib extension study showed that it was well tolerated and adverse events were generally mild. We hope this scientific data and information will help you in confidently prescribing Pulvolt 2 mg from Zuventus Healthcare Limited.
Well, this was a short video, and I hope you must have got some insight of pole vault with this. Now, let's start the ball rolling, and I would like to ask our panelists to comment on the various questions which are commonly asked by the orthopedicians and other fraternities. So first of all, I would like to ask question to Dr. Ram Chadda. So Dr. Chadda, it's all yours now. The question would be like, do we really need new NSAIDs? I mean, there's so many available. And what are the shortcomings or limitations of the currently available NSAIDs?
Basically, we as orthopedic surgeons have NSAIDs as a part of our regular prescription in the office that we practice. And a lot of us also use them over a period of time post-operatively. As I look at it, as the population is aging and as we are having a lot of chronic ailments coming in, and orthopedics is one subspecialty where people are looking at quality of life, pain being the biggest offender. a lot of people are desirous of having safe pain medication, which is anti-inflammatory in action. Over the years, we've used similar drugs, but those which had potent side effects. We had people challenging their cardiovascular system, their GI system, their kidneys, and we had huge issues as far as side effects of this very group of drugs, which came in maybe about a decade and a half back. So today, if we are going to have a good NSAID, which gives safety in renal function, safety in cardiovascular function, safety as far as GI disturbances is concerned, is also useful for chronic use because a lot of our patients need it for a prolonged period of time. And something which I noticed and I really appreciate, adherence to treatment where you have an OD dose or a single dose per day. So
Correct.
I am extremely impressed by these particular additions to our armamentarium with polmacoxib. So I am actually getting drawn to this, and I would appreciate if my physician colleague, Dr. Tewaskar, actually enlightens both Dr. Pal and me more about this molecule and gives us some insight how we should use it safely, and it should be our go-to molecule.
Definitely, that's true. We'll invite Dr. Tewaskar very soon. Now, another orthopedician of fame, Dr. A.K. Paul. So, sir, I would like to ask you a very simple question. That polmacoxib now is promoted as a first-in-class NSAID drug. So, we would like to know from you, like, how is it perceptibly different from other coxibs which had been available earlier?
Absolutely. Actually, basically, osteoarthrosis, basically in osteoarthrosis, basically it's a degenerative condition. But once it has come to us, the patient with osteoarthrosis, when there is a inflammation sets in. So we are looking for the better anti-inflammatory analgesics. So there are several analgesics already in the market, which but problem is, as the osteoarthrosis is a chronic disease, we require a long-acting, very potent anti-inflammatory analgesic, which will produce a significant pain relief for long period with safety. Now, polmacoxib is a wonder drug because it is basically a dual mode of action. Basically, previously what we are using as an anti-inflammatory were COX-2 selective inhibitor. But the same thing, say the COX-2 selective the inhibition, that leads to similar side effects when this inhibition occurs in specific organs, which is undesirable, like in the heart, lung, kidney, and also the other GI system. But the problem, the good effect of this polmacoxib, the polvol, is basically it acts as a dual action. It not only blocks the COX-2, but it blocks the carbonic anhydrase, which is abundant in our system. And it is some organs like in the heart, lung, renal, and the GI system, where the abundance of carbonic anhydrase. So it blocks the carbonic anhydrase there. Whereas in the osteoarthrosis in the knee joint, where there is a high inflammation, where there's as the coxibs now as concentration of the coxibs are much more, they block the coxibs there. So it's a extremely tissue specific because it is dual mode of action. It not only blocks the COX-2 but also the carbonic anhydrase. So in other tissues where its action is undesirable, it acts on the carbonic anhydrase. It doesn't act on the coxibs. That is how its side effects can be avoided. So this dual mode of action is extremely important, and because of this tissue specificity, because it is carbonic anhydrase is abundant in everywhere.
Very well said. Very well
Suppose
said.
in the any drug which is we are taking, it is taken by the blood. So in blood, the RBC, it acts on the carbonic anhydrase. So it is coming in all parts of the body. So it is extremely tissue specific. It meant sustain the concentration of the drug in inflamed tissues, and it protects the organs where its action is undesirable, like cardiovascular, renal, pulmonary, and gastrointestinal system.
Right. So we come back to the basics of the mechanism of action. Dr. Mangesh Tewaskar is the right person to ask a slightly hard question over here. Dr. Tewaskar, why polmacoxib is considered as not so hard on heart?
Yeah. So good evening, everybody, and good evening, Dr. Ram and Dr. Paul, and of course, thank you entire Zuventus team, Allad, Kamal, and everybody who's joined, and of course, Science Integra. I worked with them. Good evening to you. And Bhupesh, before I answer your question, you have selected a very special day today, because today was a day when Galileo has for the first time demonstrated the telescope. For the first time, this was done in way back in 1769, I believe. For the first time, the $1 US bill was approved. So it is a pretty important day for all of us, because especially in the astronomy, and now in the view of Chandrayaan going, really, the importance of the telescope is now more re-emphasized, and now we have what Hubble space scope, which is one of the state of art, and it's demonstrating so many I would say giants in the space area. Anyway, coming to your question now, why you are so in love with pulmocoxib when it comes to heart? So why your heart loves pulmocoxib more than any other COX-2 inhibitors that we have? Now let's basically understand how this COX-2 inhibition works. Okay, now we all know that there are two different cyclooxygenase enzymes in your body, COX-1 and COX-2. These both enzymes will make prostaglandins, and these are the hormone-like chemicals that cause inflammation, pain, fever. But how many of you are aware that prostaglandins, and especially prostacyclin, is also important for the vessel health and the platelet health? And when it comes to the inhibition of this COX, what happens is this, that the previous generation COX-2 inhibitors, or what we knew as the non-selective COX-2 inhibitors, or to a certain extent, even the selective COX-2 inhibitors that we had, they had a preferential action on the inflammation. But non-selective COX-2 inhibitors, they were not, not protective of the gastric mucosa, or they were, probably causing a havoc at the cardiac level. And as Dr. Paul has rightly said, one of the reasons is its binding, or I would say an effect on the carbonic anhydrase inhibitor. Now, why it is important to understand the specificity of this pulmocoxib is this, that this is a tissue selective COX-2 inhibitor. Now, what does that mean to us? Now, that means to us that, it binds specifically to only COX-2, and that too specifically in the joints. And we all know, as Dr. Paul again has rightly pointed out, that the distribution of the carbonic anhydrase is tissue specific. It's far more higher in the vasculature. It's far more higher in the heart. And there it doesn't go and bind, so much to the cyclooxygenase inhibitor. But when it comes to the inflammation, where, cyclooxygenase along with the carbonic anhydrase has to play a role, probably it has a very, very joint specific, tissue specific effect. So it has a vascular protective effect. It will also prevent the platelet aggregation, which sometimes is a challenge, especially because of the inhibition of the prostacyclin, that is PGI2. And of course, if you remember, and I would definitely say that Dr. Ram would definitely agree, and Dr. Paul will also agree, that whenever somebody is going to go for a high altitude climb, most of the times physicians write down a carbonic anhydrase inhibitor, Diamox, to these people. Why that is there is primarily because it has got a prevention effect to stop the capillary leaks, especially in the high altitude challenge. So whenever there is a pressure differences, there are osmotic changes which are happening in the circulation. The carbonic anhydrase has to play a role there, and that is the reason why you will never ever get, or unlikely to get, that flash pulmonary edema, which sometimes the non-selective COX-2 inhibitors, or even sometimes selective COX-2 inhibitors, they tend to have. Suppose somebody is given ibuprofen or diclofenac sodium or even nimesulide. Sometimes, especially those vulnerable class of the patients can go into acute heart failure, and decompensation can happen very rapidly. That is unlikely with pulmocoxib that we have, because it being a so selective tissue specific COX-2 inhibitor.
That's fantastic. Such a deep explanation you have given. I think everybody is clear with this now. And with this, I would like to,
because we need to understand, in heart and all, whenever you talk about an acute joint related inflammation, right, you don't need any more inhibition or COX-2 inhibition or carbonic anhydrase inhibition or action on the heart. You need it specifically working on the joints or the area of the interest.
Correct. Very true. We don't want action on heart and other soft tissues
yes.
where it is not required, actually. You're right.
Correct.
Okay, so I would like to invite Dr. Ram Chadda on another burning issue is that, like Dr. Ram, we have seen in past that there are so many other COX inhibitors which had been available, especially COX-2 inhibitors, and they were issued warnings regarding the use on like, as they can cause arrhythmias, etc. So what are the main concerns that you think are there with the NSAIDs of that kind?
So we distinctly remember, and rofecoxib is one of them that we have had to use and then stop using rather abruptly, and a few other coxibs as well, where we had issues which restricted the use, which are predominantly beyond the purview of an orthopedic surgeon. Unfortunately, we had no control over their cardiac and GI side effects, which were the two major things which were affecting the use and denied us prolonged use of the same medication. So there was a short-term safety, and that short-term safety also was not as ideal as it ought to be.
Correct.
Hence, we were struggling with the coxibs, which we desirous to use. They're very effective, but we were unable to use them for that reason. Yeah.
Sure. All right, Dr. Pal, if I may ask you, unlike all other NSAIDs, pulmocoxib is given just once a day. Can you just elaborate further on this?
Absolutely. So we are also on the look for the very convenient dose, which is very compliant for the patient. And surprisingly, or pulmocoxib is it is a long time it lives in the system. It is well taken in the system. It remains in the RBC. I've already told it is combined with the carbonic anhydrous of the RBC, and it remains in the system for a long time. That is, it is seen. It remains in 127 hours plasma without 33. That means almost 5 days. So it is no need of giving other than once a day. So very small dose, 2 milligram once a daily dose. It is extremely sufficient to maintain its therapeutic action on the inflamed tissues. It is a joint specific. It is very inflammation specific, joint specific. And it can maybe orthopedic specialist. I can tell you, the orthopedic specialist is a very good drug for the orthopedic.
Right, absolutely. And another question to Dr. Ram, like adherence to arthritis or arthritic medications is generally very poor. What are the main reasons for the non-adherence to these NSAIDs?
Well, couple of things. One, we as patients are very poor patients as regards adherence to therapy, because we look at only short-term relief of pain and deny that inflammation part. And hence, anything more than once a day, twice a day or thrice a day is often forgotten. That's first. Second, we also have this tendency to get carried away by the number that is written in front of the drug. Like 50 milligrams or 100 milligrams is far more scary than a 2 milligram dose. Although that is not something that is true, but is something which is unfortunately interpreted by the user as more potent or less potent, and more side effects or less side effects. The other thing which we've also found is that if we counsel the patient about prolonged safety, their adherence to therapy is far superior. And unfortunately, the previous medication and previous coxibs that we used, we could not really do that counseling. We could not give them that confidence of taking it for a prolonged period of time, especially the people suffering with chronic osteoarthritic ailment, which is probably the commonest patient visiting an orthopedic surgeon today with knee, back pain, or any one of those joint pains, where this drug is the most efficacious. So it has helped us and will help us in a big way. We still don't have as much studies, but I believe there is a study of a 6-month use without any untoward effect. So I think that's a fairly long period of time to take 2 milligrams every day for 6 months and have no real side effects. I'm very impressed by that fact.
Right, right. Yeah, so just related to this question only for Dr. Paul, like, what are kind of long-term safety studies available on this?
Yes, there is a excellent study, which is a randomized, multicentric phase 3 trial, even a double-blinded study, which is compared the efficacy of the celecoxib 200 milligram BD versus 2 milligram Polvol. It's by Manchul Lee et al. In 2017. It is published in Clinical Orthopedic Surgery. This excellent study here initially is the compared the safety and the efficacy of both the drugs in 6 weeks period, which is again extended study of another 18 months. So there is total 24 months of 362 patients. And I have seen they have seen that there are 324 patients already completed the 6 weeks, and that's all overall 220 patients over among 362. They have completed this 24 hours the extended study, and they compared the efficacy and safety by different parameters like clinical parameters, like with vital signs, as also some different laboratory tests considering the different the parameters of judging the different vital functions like cardiovascular functions, like ECG, there are renal functions, the urea, creatinine clearance rate, lung function for the pulmonary system, as also the GI system. Also, there are different parameters that they are compared, and they have shown that it is extremely safe. The pulmocoxib, this pole fault is extremely safe in a 6 weeks period with a very mild side effect, whereas in extended 18 weeks study, it's shown that it's extremely safe in cardiovascular, gastro, and renal safety. Overall 24-hour weeks experience shows it is a well-tolerated, pole fault is well-tolerated with mild side effects, especially the gastrointestinal side effect, and very few cases they showed some pedal edema in first 2 weeks, which is gradually it is removed. It is no extra precaution or any rescue medicine is required during this period. So it is extremely safe in this overall 24-week study.
Right, sir. So, is there any superiority of pulmocoxib over celecoxib?
Absolutely, absolutely. And this Manchul Lee, they have shown there is absolutely pole fault is extremely superior, because in I mean they have shown there is a WOMAC parameters. When Western McMaster, Ontario and McMaster University score, they have shown this extremely sensitive score. They have shown that they have the pain relief is extremely quicker onset of action with pole vault in 3 weeks period. It is extremely quicker, whereas there is no statistical significant pain relief in celecoxib versus some placebo in 3 weeks period. So with pole vault, the pain relief starts from 3 weeks onwards, and in the 6 weeks, if we compare the pain relief and the stiffness, they have significant symptomatic relief, which is extremely statistically significant in comparison with the placebo with pole vault, in comparison with the celecoxib. Not only that, at 6 weeks period, in pole vault there is 77.7% patients showed the satisfactory symptomatic relief in respect to pain relief and the stiffness, amelioration the stiffness of the knee joint osteoarthrosis, in comparison with only the 58.9%, that is almost 20% less in celecoxib. So in that study, they have clearly shown that the pole vault is extremely superior in action and in our clinical study in 6 weeks to extended 24 weeks period in comparison with the celecoxib 200 milligram BD.
Right. That's very interesting, actually. Dr. Mangesh Tevaskar, if I may ask you, there are many cardiac patients who may be taking aspirin or low-dose aspirin daily. Is it okay to take pulmocoxib along with?
Yeah, and in fact, good question, Dr. Bhupesh, and I can tell you that a majority of the times, if you ask a physician like me, probably, and if he or she comes to know that probably somebody is on with NSAIDs and especially the COX-2 inhibitors, we really get scared, basically because if you really look at and compare the effects of the non-selective versus this selective versus even the specifically tissue selective COX-2 inhibitors, we have to realize the difference, how they act, honestly speaking. Now, if we all know that, it's an arachidonic acid guided pathway where probably, COX-1 have effects on 2 platelets COX-1 actually, what it does is this, that it triggers the thromboxane A2. It protects the thromboxane A2 from getting triggered. And that will definitely help in preventing the thrombosis. As far as the COX-1 effect, again, on the gastric mucosa is concerned, usually the effect is usually through the prostaglandin E2 and I2 that we know, that it offers a gastric protection through a COX-1 release. And if you talk about the COX-2 in the endothelial cell specifically, which is acting through the prostacyclin, that is prostacyclin or a prostaglandin I2, its effect is vasodilatation and again reduction in the platelet aggregation.
Okay.
Now, whenever there are these drugs like thromboxane A2 inhibitors, like low dose aspirin, or maybe probably the patient is on with the dual antiplatelet agents.
Correct.
You worry about the excessive GI bleeds, especially can really be challenged.
Right.
And especially during this period, probably these patients, they become vulnerable. So the specialty of pulmocoxib here is this, that being just so specific to the joint COX-2, it does not have any effect as far as the COX-1 in the platelets, COX-1 in the gastric mucosa, even COX-1 in the endothelial cells. So you can easily and safely ask patient to continue with low dose aspirin, or I would go a step ahead and say that even with the DAPs, of course, the caution is always given to the patient, but it's much safer. And more importantly, we don't understand this much, but unfortunately, that will also help you in reducing down the misuse or overuse of proton pump inhibitors, which is so rampant in the practice. And especially orthopedicians and most of the people, those who are prescribing, these kind of NSAIDs, they would definitely love their patients to be protected GI-wise as well, isn't it?
Right.
Now, if you have got a COXIB, which is GI friendly, which does not cause erosions, along with that, it works very specifically to the target, I would love it, isn't it? Because overuse of PPI will not only, will hamper the overall oral mucosa regrowth, the pathogenesis, but it have an effect on the gut microbiota. It really pushes gut microbiota in a bad way. So your metabolic milieu goes for a toss. And if you are using it, injudiciously, and especially diabetic who is hypertensive, who has a ischemic heart disease, has a low ejection fraction, already has gastric autonomic neuropathy, now you will require the drugs which will be more specific in the action.
Correct.
This is the greatest advantage of pulmocoxib over the roxaparvir.
But then if we consider all other COXIBs, so all COXIB must be having same mechanism. So are they actually same, or there is some difference between pulmocoxib and others?
Yes, there are differences between the pulmocoxib and others. And I have tried to tell you that primarily it does not cause any effect as far as the platelet function is concerned, which because other COXIBs are so non-selective or more towards, selective, but they do not have a specific protective effect as far as the thromboxane A2 is concerned, or the COX-2, which has got a vasodilatory effect is concerned. That is not affected by pulmocoxib.
So are there any cardiovascular warnings or any other serious GI side effects with pulmocoxib, or there is none?
No, honestly speaking, in comparison to the other COXIBs, I can easily say that pulmocoxib is a much safer choice. Of course, we need to educate our patients. We need to tell them what are the warning things that they should be watchful for. And if at all there are anything like this, they should report. But the chances are unlikely or less likely in comparison to other non-selective COXIBs or the broad spectrum NSAIDs, I would say.
But Dr. Mangesh, like the way you explained that because of its specific action on carbonic anhydrase, where it is getting like sponged out by other sensitive organs, does this interaction with carbonic anhydrase, it actually affects the physiological function of other organs?
Other organs also. And in fact, it has got a beneficial effect on the RBCs, as Dr. Paul has already said that, they have got a wonderful ability to stick to this RBCs for a long time. And also they do have got an effect as far as the platelet aggregation is concerned.
Correct. And what about cardiorenal safety? Renal safety specifically.
Renal
currently we have
safety
discussed.
still, it's not completely ruled out, to be very honest to you. You should be very careful as any other NSAIDs you would be,
Right.
because renal safety is an absolutely different ball game. But I can tell you that you can say that in up to around stage 3, and I would say stage 3B nephropathy, you may have got a choice. And if the pain relief is a major factor there, you don't have anything except probably paracetamol there, or tramadol there, which is there, or probably, you have got this morphine derivatives there. Here I have a drug which can be even prescribed up to stage 3 nephropathy, where EGFR is around I would say 60.
The same question to Dr. Ram Chadda in his practice, like, what do you feel about the renal safety of this product?
Well, it's extremely important. I mean, as I look at it, I look for renal safety in 2 major prescriptions that I use every day. One is the choice of my pain medication, and the second is the choice of my anti-osteoporotic medication. And believe me, out of 20 patients a day that I see, maybe 10 of them need both these medicines together. Okay. Hence, for me, something which can be used with an EGFR of 60 is a big plus point in my practice. Something that can be used besides paracetamol and tramadol and morphine in renal challenge is a big plus to my practice. And when it belongs to the COXIB group, the amount of relief that they get, and I know that, I think it's a huge value addition to our practice. So okay, I am totally convinced that it works well.
Right. And what are the risk mitigation strategies you take for high-risk patients?
As far as
NSAIDs, yeah, when you give NSAIDs.
Well, I'll be very frank. The moment I used to have anything, I mean, EGFR 60, which has been told today, I mean, it's a revelation for me. I stopped with my NSAIDs at a much safer level than that.
Oh, is it?
I tend to upgrade on my paracetamol doses. So that's the biggest risk mitigation that I indulge in. So that's how I work.
That's very good. In fact, it's all a very practical and useful information we are getting from the eminent panelists. In fact, there are certain questions which are coming from the viewers who are currently in the show. There is one query from Professor Dr. Venkatachalam Krishnamurthy from Trichy in Tamil Nadu. He says that carbonic anhydrous therefore has an essential role in facilitating transport of carbon dioxide, bicarbonate, hydrogen ions across falling cell membranes for a variety of processes. Correct. Erythrocytes, where carbonic anhydrous contribute to carriage of carbon dioxide transport from the tissue to the lungs, stomach, pancreas, so many other places, brain, etc. And will it affect that? So
no. So the answer clear is
yeah, Dr. Mangesh,
the answer clearly is no, it will not. And as you rightly pointed out, that's exactly what the role of carbonic anhydrous is there, and more towards the tissue, I would say gaseous exchange, maintaining the acid-base balance, maintenance of the fluid balance. All these things, carbonic anhydrous inhibitor, it has a role. Now, being so specific in the joint effect, where COX-2 is much higher and the carbonic anhydrous is much lower role to play as far as the inflammation is concerned. And if you really have an effect of that in opposite to exactly what happens to heart, I believe pulmocoxib is the safer choice, and that is the reason why we say that it will not cause, or it's unlikely to cause flash pulmonary edema, or the trigger of, even I would say, go ahead and say the trigger of probably an episode of bronchial asthma or COPDs, where you are really worried about these patients, and especially drugs like diclofenac, you would not like to give them. Aspirin even to a certain extent, or ibuprofen to a certain extent, especially in the patients, those who are allergic asthmas, COPDs, you would love to be careful with them. I think this drug would definitely solve a lot of headaches of the prescribing practitioners as far as these conditions are concerned.
And just correct me if I'm wrong.
Can I comment on this? Can I comment?
Sure. Please.
This is a very good question, but basically there's the answer of this, whether this drug can block the physiological action of carbonic anhydrase or not. Basically, this is the question. So basically, carbonic anhydrase is an enzyme which acting as a which produces the buffer system in our body. So it's acid-base balance. And Dr. Saab is asking whether it affects this buffer system in the lung or not. Basically, basically there are several other drugs like acetazolamide that selectively blocks the carbonic anhydrase, but this polmacoxib this doesn't that type of drug which completely blocks the carbonic anhydrase. So that it is special affinity to act on a special moiety, that is aryl sulfonamide moiety, which is common with coxib that is the coxib 2 enzyme as also this carbonic anhydrase. So that is how it blocks the carbonic anhydrase in some areas where it is abundant, as in this system, in the lung, the different systems. So that is how it works. That doesn't indicate it completely blocks the action of carbonic anhydrase in those areas. So that is there are several other drugs like carbonic anhydrase. That is acetazolamide. Acetazolamide that can block the carbonic anhydrase. That is how it is useful for some carbonic anhydrase induced diseases like the glaucoma, the macular edema, epilepsy, like that. But it is not the pole ball. So that is how it is safe. It cannot block the physiological action of carbonic anhydrase.
So that's what exactly I was trying to say, that where the tissues where you have got a large amount of carbonic anhydrase, it will not cause much of the effect, and especially in the tissues where you have a small amount of carbonic anhydrase, maybe probably.
If I'm not wrong, correct me if I'm wrong. Like one is the physiological action where all this being produced continuously, and other is the induced form, like COX is just induced in certain organs where inflammation is there.
Inflammation related induction.
Yes. So probably that again equation will set in, and you would not like to give pulmocoxib to non-arthritic patients or non-inflamed joint patients. So probably then the question of normal physiological inhibition will not be much. So there is another question, very interesting one, from Dr. Dayanand Jangir from Jodhpur, Rajasthan. He's asking, what is the lethal dose of pulmocoxib 2 milligram capsule? And is pulmocoxib 2 milligram capsule has tachyphylactic effect?
Now, as far as the drug interactions are concerned, probably yes, you need to be very careful when the pulmocoxib is prescribed along with ketoconazole, ACE or ARBs. Diuretics, you should be careful. Lithium, methotrexate, the drugs like warfarin, cyclosporins, or tacrolimus, disease modulating agent, or even with corticosteroids, you should be careful. As far as the lethal dose is concerned, I'm not really truly aware about it. It's a good question. Probably I would also love to read about it. But I think this is a fairly safe drug because whatever I understand about the pharmacology, and probably Bhupesh, you would be able to tell us in a better way that maybe probably the approved human dose is at least 10 times lower than the acceptable pharmacological dosages.
In fact, in animals, this dose is found to be 100 times more than the human dose. It is 100 time difference.
Yes.
So this particular dose would be very, very safe that way.
Yeah, so be careful only while co-prescribing with these drugs, as I mentioned.
Correct.
And especially with ACE/ARBs, ketoconazole, corticosteroids, methotrexate especially, coumarin derivatives. You should be careful. Diuretics, and that too loop diuretics. You should be a little careful about prescribing this.
That's very, very true. Okay, so just moving on to a few more questions. Like there is Dr. Jagdish Gehlot, again from Jodhpur. What is maximum dose in a day a doctor can prescribe to patients to relieve chronic pain? So 2 milligram is the one which is recommended, and it is to be given regularly for a continuous period of time before we actually see the perceptible change in the arthritic condition. Dr. Kumara Mani Jaina from Cuttack, Orissa. What is the side effect profile of the molecule? Any contraindications?
Yes.
Dr. Mangesh, I think you have just discussed that.
A good question about it. Especially, I would like to specifically mention about the contraindications. Number one is, as usual, a very standard answer. If you're appearing for an examination and if you don't know the answer, Dr. Paul will be seeing so many of the students answering this, that allergy to the drug. So the same answer, if somebody is hypersensitive to pulmocoxib, you should not be giving. You should be extremely careful about hepatic impairment patients. Always remember, and especially child's class 2 ahead, you should never be giving. Renal impairments and acute renal shutdowns, acute kidney injuries, or the EGFR below 60, you should be careful. So stage 3 nephropathy and below, you should be careful about it. Somebody has a history of an acute pulmonary or acute GI bleed or a peptic ulcer bleed, you should be very careful. Pregnancy is an absolute contraindication. It is not indicated in pregnancy at all. In nursing mothers also, you should not be prescribing this. And especially in the elderlies who are highly likely to have the renal compromise or very unstable cardiac function. I would not say it's a contraindication, but there you would love your patients to be careful. And I want the prescribing physicians or the doctors should be also very, very watchful in this kind of a vulnerable class. And special precautions to be especially taking, as Bhupesh you asked about the dose of aspirin, you should be careful. Some people, they have some of my patients in whom I have used in my whatever limited experience that this patient, some people initially complain of little dizziness and drowsiness especially, so they should be careful while driving. It is very important. And lastly, it is extremely important to avoid alcohol, so which are going to make a lot of patients unhappy about it. But a very, very strong warning has to be given to avoid simultaneous alcohol when you are on the drugs like pulmocoxib.
Right. Dr. Ram, there is a very interesting question coming from Dr. Debashish Majumdar from Midnapur, West Bengal. He's asking, is osteoarthritis a degenerative disorder or an inflammatory disorder? How can you justify its use in osteoarthritis long term?
So it is a degenerative disorder, but it has acute remission exacerbations, not as active as with acute inflammatory disorders like rheumatoid arthritis. But there are patients who go through good phases and bad phases. And whenever they're going through those bad phases, they do need medical support. So one is, yes, the patient accepting, but the fact is that pain cannot be lived with forever. And hence, we have to use it both as far as its analgesic and anti-inflammatory actions.
Can I add to it?
Yes, please. Please. Sure.
Yes. Basically, there are two terms. One is osteoarthrosis, another is osteoarthritis. Okay. Basically, it is deliberately given that the question is whether the hen comes first or the egg come first. That is this answer is the same. Basically, it's osteoarthrosis. So osis means once this term is added with the word, this is a degenerative disease. Now, which has come first? Osteoarthrosis. From which structure the disease comes? It is basically the articular cartilage. Articular cartilage is divided. It has no blood supply. It has no nerve supply. It has no lymphatic supply. So how the inflammation comes? So basically, it is a degenerative disorder. Once the articular cartilage is damaged, then once that degrading product that invites inflammation, that is, the inflammation comes later on. So once there's osteoarthrosis, basically it is a degenerative disorder. When the inflammation sets in, patient becomes symptomatic, and then he goes to the clinician. So that is the basic theory.
Wonderful, wonderful. That's so nice. Okay, so I thought this is a very, very good discussion we had of late, in so many seminars we were conducting, but a very, very practical discussion.
I think, Bhupesh, one point we need to insist for all our listeners and this may not be a drug for an acute effect.
Correct. It's for chronic disease.
If you are looking at this drug to reduce down the acute pain, probably you are making a wrong choice. But you want to have the pain-free maintenance phase. Probably this drug can be wonderful opportunity. So be very, very careful. Use it, have it feel, and then probably you'll realize that you have a far better tool than what we thought about.
Right. So, no, I think it's so engrossing. I don't want to leave this session, and I'm absorbing just like pulmocoxib. I'm absorbing all the information from you guys.
In fact, I was so impressed by Dr. Paul. When he was talking about carbonic anhydrase, I was wondering, am I a physician or is he a physician? Who should be supposed to know about it? I was
Of
really,
course.
really impressed with Dr. Paul that the way you explained that carbonic anhydrase, it was really, really lucid and very simple.
Excellent. Okay, with this, I would like to invite Alad Mahajani to give a vote of thanks.
It has been a wonderful discussion. I'm greatly thankful to Dr. Ram Chadda, Dr. Mangesh Tivaskar, and Dr. Pal for the wonderful, insights. These are pearls of wisdom probably which we will carry with us, and I'm sure all those esteemed audience who has joined us to learn about management of chronic inflammation and pain would definitely carry it with them. So I sincerely thank you, sir, for the esteemed panelists, each one of you, for taking the time out of the busy schedule. And also all the esteemed guests who have attended this session, a sincere thank you on behalf of Juventus. We must also thank Science Integra for carrying out this program seamlessly well, and we are obliged. Thank you so much.
Now, before we depart, one liner for pulmocoxib from each of the panelists. So to begin with, Dr. Ram Chadda.
Well, just because I've got the chance to speak first, I'll use something that I use very, very often. Is better safe than sorry. So it's a drug where if you don't use it, you'll be sorry. And believe me, it's safe. Great.
Very nice. Dr. Paul, please.
Yes, as I looked at this drug, the osteoarthritis, I've already explained. Osteoarthrosis is converts to osteoarthritis is the inflammation. Osteoarthrosis plus inflammation is equal to arthritis. So that is the drug. We have to choose one drug, which is extremely helpful for reduction of the inflammation as also symptomatically. So in this way, it's a convenient once daily dose, highly potent anti-inflammatory analgesic is a pulmocoxib, which is extremely safe also.
Lovely. Very, very good. Dr. Tivaskar, please.
Thank you, Bhupesh. And before I say my last line, I would like to put my appreciations to you, because the success of the program depends on the moderation. And you moderated it very well. And of course, a huge thanks to all our audience, those who have shared their time. Today is a practicing day, and not many of us are lazy. Not many of them are lazy like us. Doing this kind of webinars, they love still practicing, and out of that they have taken out their time. So that really imparts the love, and that again insists and makes me believe the fan following of Dr. Ram Chadda and Dr. Pal. This is wonderful. So thanks everybody, those who have joined. And my line would be that here is a drug probably, it may be an orthopedician's dream, but it would not be odd to say that it has solved a lot of physician and cardiologist nightmares. So especially when it comes to pain, we are very insensitive as far as the management of the chronic pain. We need to get sensitized to it and address this challenge, because that is one limiting factor which is sometimes makes the patients vulnerable, and also they stop believing in doctors. Here is a drug probably which is fairly safe, which can be fairly well used. Of course, the necessary precaution needs to be taken, but of course, it's a drug which may probably change the way we manage our chronic painful conditions.
So nice. Thank you so much, Dr. Tivaskar and Dr. Pal and Dr. Chadda for your wonderful contribution to today's webinar. Thank you very much, and have a very nice evening. Thank you.
Perfect. And Allah is looking as handsome as he should be. So very nice. Chalo, bye-bye. Good night, everybody, and take care of yourself. It was a pleasure joining you, and Dr. Paul, it was an honor to know you. Thank you very much. And of course, Ram, sir, good evening and a salute to you. Chalo, bye-bye. Take care of
you. Sir. Thank you so much.
Bye. And bye, Aditi. It was lovely seeing you after a long time on the platform.
Definitely.
Bye-bye.
Nice meeting. We have enjoyed a lot. Thank you.
Thank you, sir.